Good afternoon. How are you? Good afternoon. Welcome, Shannon. Thank you, Shirley. Hello, face over Shirley's shoulder. Can you, Shirley, can you give me, can you private message me Norma's email address? Her CDP certificate bounced back. Welcome, Teresa. Thank you, Teresa.
There you go. I am going to. Hal.
Do you want me to mute you? Welcome, Ashley. Welcome, Sam.
Hi, good afternoon, everybody. Let's see.
We're getting started in just a few minutes. If you haven't put your name or anyone with you in the chat, please do so. We'll be getting started in just a few minutes. I'll figure it out.
Hey, Chris.
Hello, everyone.
And we got the time correct this week, so on our slide.
Welcome, Michael. Welcome, Ashley. Welcome, Cynthia.
So I missed being here last week and I'm still catching up on emails. The price of vacation. I hope everyone gets a chance though to get away this summer, even in just some small way. Beach trip, highly recommend.
That sounds great.
Yeah, my son just moved to Charleston, so we went to South Carolina to check out his new environment. Folly Beach, highly recommend.
Did you make it to the Jack of Cups?
No, wait, you didn't tell me about this. What did I miss?
The Jack of Cups is on the main avenue, and it was like we went there the last night we were there, and we were just blown away at how good the food was.
I'm going again in August, so I'll be sure not to miss it. No, there was a restaurant called Low Lifes, and I felt that I needed to go check that out.
I mean, if you looked at it from the outside, it looks like a total dive, but like the food, I just could not believe how good the food was.
Jack of Cups, okay. On
All
my
right.
list.
It is 2:00.
Before we get going, Justin, can I just check in with people about the CDP certification? You all should have gotten your official certificate and a link to the website where you can register. I want to encourage everybody to do that, although I know that it's somewhat onerous, truth be told. I haven't been able to finish mine yet, but they've asked us all to finish that by June 17th. So if anybody's having trouble making that website work, originally we were going to try to do this paperwork for everybody, but honestly, we don't have all the information that they're asking for. They want your background. So I know in the morning cohort, we had maybe about a dozen people saying, thumbs up, they got it done. If you're having struggles with it, email me and Jennifer. She's not with us today, but you can hit us up at that CGWEP email address or at her email address, Jennifer_Hubbard, et cetera, and I'll stick her email in the chat. Is anybody's hair on fire with respect to the CDP? Scott says it took a while, but once you got it done, it was worth, thank you, Scott. Persistence, we appreciate that. It's worth jumping through the hoop. And we're super happy that we could bring you the training and bring it to you for free as part of this Echo series. Thanks, everyone.
Thank you, Chris. So Justin, do we want to go ahead and get started? Any other announcements?
We'll have some announcements at the end. Pam will, but this is just a reminder that this is week 19. This is behavioral health and trauma informed interventions, and week 22 through 24 we'll move into health disparities and social determinants. We'll be talking about the once a month sessions after week 24 in the next couple of weeks, just to kind of talk about how we'll be transitioning. But now I will, if you could advance the slide, Sam.
Got it. Sorry.
So at the end of this week, please complete the short session 19 survey. And today's presenters have nothing to disclose. So now I will introduce Sam Cotton and Barbara Gordon.
Hi, everybody. We're so excited to be with you this afternoon to talk more about some age-friendly and trauma-informed strategies for dealing with some of the behavioral health challenges that we know that you're probably facing at your nursing facilities. Barbara, do you want to say hello really quickly?
Hello, everybody. Good afternoon. It's good to be with you.
And we thought we would start quickly by just having this. Yeah, Justin, you need to say something.
Well, the person who submitted this is not here yet. So I don't know if we want to see if anyone else on the call has a case that they'd like to talk about or any kind of challenge that they'd like to talk about, and maybe we'll come back to this.
Yeah, because I think it's a really solid case and really fits in with our discussion today, but we can hold it for later. And if anybody has, to Justin's point, anything else related to behavioral health, whether it be behaviors that some of your residents are dealing with, maybe even just things that you're noticing related to depression, that you're struggling with that you'd like to share, because we're going to be talking about some of those strategies today for dealing with that. And you can unmute, put it in the chat, whatever works best for you. Or I will also say too that if you're dealing with, now last week we talked about challenges related to staff not wanting to get the booster. And that came up this morning in the call as well, as somebody had from the morning sessions actually submitted a case where that was a challenge for them. And so what I did was point them to Jennifer and Justin sent out emails last week with all the links that we had discussed during our session on fostering age-friendly and trauma-informed care within your facilities. And one of those links that was listed was the document I referred to, or the website I referred to from Johns Hopkins, that has some pointers when talking to people who are dealing with vaccine hesitancy. So if you're struggling with that, that's a great resource to really start that conversation. And so in the interest of time, then we're going to go ahead and move on with some of the other pieces of our workshop. And if you think of something, please share it in the chat. If Morgan shows up later, I'll have her present this case so she can kind of give us some more information about that. Otherwise, I'll take us back to the slide because it's very relevant to what we're discussing later on, and talk us through the pieces of the puzzle that we know. So today we're going to discuss strategies on how to compassionately deal with behavioral health challenges. And, I would say that I really want to strongly stress that we know that you have all dealt with residents' challenges related to mental health, even before the pandemic, right? But COVID-19 really exacerbated some of those issues that were already there, and some of those challenges that you were probably already dealing with residents. And in terms of exacerbating some of those issues, you had a complete disruption of routine for most residents. In some situations, you were having to cohort them based on their COVID status, which caused disruptions. Maybe somebody who had lived with a person for a really long time had now had to move to a different room with a different roommate. And those, all of those dynamics cause challenges. Lack of physical touch, not being able to even give people a pat on the back, or of reassurance sometimes really cause challenges for our older adults in our nursing facilities. That lack of socialization, part of the reason a lot of folks want to move to a nursing facility is so that they can have, roommates essentially, and people that they can socialize with on a regular basis. And so that's one of the issues that we saw a lot with, the pandemic. PPE, very confusing, especially for our folks with Alzheimer's disease and related dementias. Not being able to see a person's mouth while they're talking for those folks with hearing impairments, really just caused that distance or that isolation, even though they might have been around people on a day-to-day basis, that the PPE really caused a distance in terms of that personal approach that we often apply in our nursing facilities in working with individuals. And then, across the board, there were probably challenges related to limited visits from family and friends. So individuals who might, be in a nursing facility, but maybe their spouse lives out in the community, but they come over and see them every day. Those challenges were there and really caused some additional mental health issues for our older adults. I would say too that in terms of this, again, just to express that this is one of those situations where it caused more of an issue across the board. And, we're seeing things like depression and anxiety, and we know that that can manifest in different ways for individuals. Not every person who's depressed is going to stay in bed all day, right? They might have changes in mood and behavior that you can observe that's not necessarily in alignment with some of those more traditional ways of talking about depression. Same goes for anxiety. We often see that with individuals, it manifests in different ways. They might become more agitated, or they might have more repetitive behaviors. And so really struggling in some of those areas can be problematic and can be a challenge for our residents. And so what I would like to introduce to you today, and this is very much in alignment with our CDP curriculum that you just went through those 8-week sessions on, is compassionate care. And it's an age-friendly and trauma-informed way to really look at the mental health challenges that some of the residents at your nursing facilities are dealing with. And when we talk about compassionate care, we're really focusing in on daily caregiving and what that looks like for your CNAs, for your direct support staff, for all of you who are invested in what's going on with the residents that you're working with. And a lot of times we focus a lot on what we call that basic nursing care, that basic care piece for our individuals and some of the things that they are struggling with. So maybe they need help with bathing, dressing, feeding. Maybe they're needing help with medication management, being able to do that. Maybe they need help with transferring even from their bed to, wheelchair, for example. And so we see some of these challenges over and over again with individuals, and we need to attend to those. Obviously, that's part of what we do at our nursing facilities. But with compassionate care, it's really about taking it and not dismissing that basic nursing care that needs to happen, so important, but really taking it up a notch and also recognizing, in addition to those basic nursing care pieces, recognizing the suffering that the individual is going through and providing care to alleviate that suffering. And when we talk about suffering, we see that quite a bit in our residents in various different ways. We see it a lot with persons with dementia. Those moments of maybe they have moments of clarity where they know that they're forgetting things or know that they're not able to function the way they once were able to. And that causes them distress. It causes them anxiety or depression and a multitude of other things. It's also suffering too that can happen just even in that transition from living independently in the community to moving to a nursing facility, right? And that role reversal of maybe they were the caregiver, the care provider, or, even if it was just to their children, they were caregivers too. That role reversal of now needing that additional support can contribute to suffering. And so it's really about walking alongside the individual and really focusing in on how can we help alleviate some of that suffering. That can look very different for every person. Sometimes it's just thinking about even those small compassionate interventions you can do to address the behavior that that person's having in the moment. And we're going to focus on some of these various behaviors that we've heard from you that are challenging, both from your staff, but also challenging in light of some of the staffing issues that you might be dealing with, wherein you don't have enough staff to devote to whatever the unique needs are of that one individual, right? Particularly if they're agitated or aggressive or something like that. And when we talk about each of these, I want you to think about, who are those residents that who are struggling with some of these different challenges. So the first thing we're going to talk about is anger and aggression. How many of you have struggled with residents related to anger and aggression and agitation? I'm seeing quite a few. Dorothy shaking her head. Shirley, I'm seeing so some challenges there. Have you had any experiences that you would care to share that you're struggling with, or things that come up that you can think of related to the agitation piece?
Yes, sometimes occasionally it will lead to increased outbursts or the repetitive behaviors that can sometimes wear on staff, right? And trying to redirect, I think, causes a little frustration on both ends. It can be a challenging behavior, but that's something, those with dementia, Alzheimer's, that's sometimes the only way they can really express themselves. So, but it can lead to that kind of anger and agitation from caregivers, as well as the participant being frustrated or patient being frustrated because they're not able to really express what they're feeling. Cursing, when they can't find the right word.
Yeah, maybe even cursing from people who don't normally curse.
Yes.
Right? Yeah.
Yes.
Yeah. As a means of expression. Yeah. Shirley, did you have something you wanted to share? I thought you unmuted briefly. Oh, you're putting in the chat. We have a lot who are normally independent and now have to be in our home, so they have anger and have no one but us to take the anger out on. Yeah, so really being the recipient of those outbursts and really struggling in terms of dealing with, how do you navigate that, right? Particularly when you're taking care of folks who, maybe they were very independent out in the community and now they need that additional support. They're in the nursing facility. And so they view you, who the person taking care of them, as the reason for this, right? And so I want to share with you that one situation in particular that we often see is that especially with persons with Alzheimer's disease and related dementias, and again, this could also extend to not just persons with dementia. You might have the situation that's situational or contextual as well with anger and aggression, where they might, they have a situation and then you have the outburst, right? So screaming, hitting, throwing objects, spitting, cursing. And in my work, I have done a number of different things as a direct support worker, and in particular, done a lot of personal care. And did somebody say something? Okay, maybe not. Maybe somebody was inadvertently off of mute. And so in providing care around shower time, that has often been in particular a difficult situation for individuals. So we might, in the process of doing this, get individuals screaming, hitting staff, spitting, throwing soap. I've had soap thrown at me several times before when a person's, contextually very upset about the situation that they're in. So sometimes it's good for staff to take a step back and think about, what's causing this? What is the situation? Now, sometimes the situation is the fact that they are in the nursing facility and they're angry about it, right? But sometimes you can pinpoint it to these outbursts in particular, to a specific context. And a lot of times we really need to step back and focus on what's going on with the individual. Why are they presenting in this way? And sometimes it's a physical response. Sometimes they're unable to communicate their feelings. Sometimes they're stressed or tired, and sometimes they're just not understanding the situation. So if I go back to the situation that I told you about related to the person who really struggled with showering and became very aggressive around that. We do know that for some individuals with Alzheimer's disease and related dementias, this whole process of showering is very overwhelming for them. You have the noise associated with being in the shower. It echoes usually in shower situations because of the design. Even the water hitting their bodies can be very painful to them. It can cause like a sensory overload wherein, it's not comfortable. They're feeling a lot of discomfort, a lot of stress because of the water pelting them, and they're feeling it at that water pelting them at a much deeper way than refreshing, normally for us when we're taking a shower. Sometimes the task feels rushed to the individual. And so they can't comprehend what's happening. They can't understand what the steps are in order to get the shower completed. And a lot of this sometimes has to do with us as staff working with them, right? We're rushed. If it's taking a lot longer than it should, we know that we have to move on to working with the other residents. And so all of this creates that, issue around showering. And again, this is just an example of when we often see people become agitated or aggressive. But something that can help with this is really thinking through, how do I communicate to this person I'm working with what we're about to do? So instead of just saying we're going to take a shower, which they may or may not remember what, the connotation of what that means, particularly if they have dementia, it's sometimes walking them through the steps and saying, okay, we're going to take this article of clothing off first. We're going to put one foot into the shower. Now we're going to put the other foot into the shower. Now we're going to turn on the water. Here's the soap. Walking them through all of that piece can be very important. The other thing that I would suggest too is creating that calming environment around this, whether it be shower or another situation wherein maybe you're looking at things like, if a person likes music and finds it soothing, that you're playing that softly in the background. I worked with a individual who had a lot of anger and aggression surrounding shower time and transferring in general. He was a person that needed to be transferred from the bed to either a Hoya lift to get for toileting purposes, or to a wheelchair for navigation, like throughout the facility. And we would sing while we did that because it was awkward for him. It was not, particularly pleasant when we had to transfer him from setting to setting like that. And so we would sing together, we would hum things, and that to him, like, took him away from what you were doing in that moment and made it more pleasant for him. For some individuals, smell can be a really important tool. So if it's an option to use essential oils, if it's a shower time, having a diffuser in the bathroom could be helpful. So really thinking about what's causing the stress for the individual, and how do we help eliminate that particular piece. You also want to always look at, when you get anger and agitation that is out of character for the individual, let's think about that physical discomfort that might be precipitating that. So is the person really struggling in terms of pain from the activity or pain in general? So, thinking about things like UTIs, and, there's pain associated with that, right? But not everybody can verbalize that they're feeling that discomfort. And so that can cause them to be moody or agitated. Is the person tired? Did they get too much stimulation at a particular activity earlier in the day? Has there been a change in medications? And often this can be a larger conversation that you need to have anytime somebody changes medications, to make sure that they're not having adverse side effects related to that particular change. And then things like hunger and thirst. And we talked a lot this morning about individuals once they are hungry and they don't know how to say I'm hungry, particularly those individuals with Alzheimer's disease, really seeing a marked change in their demeanor or their behavior, and trying to figure out, okay, what is going on with them. And sometimes it's just simple things like they could be dehydrated, so they could be thirsty, or they could be hungry. Same goes for individuals who have diabetes or other blood, have anything related to irregulation with their blood sugar levels. So making sure that you focus in on those particular individuals and making sure that it's not the behavior is not associated with some of those changes as well, can be very helpful. And then in terms of responding to situations and fostering safety, because sometimes with agitation and aggression, we see a ripple effect, right? It doesn't just impact the resident who's agitated and the staff working with them. It can cause disruption for all the residents who are in that person's, physical proximity while this is going on. So making sure that you identify the immediate cause so that you can really make sure that you're attending to the situation quickly so it doesn't linger, that it doesn't cause that ripple effect, immediately focusing in on that. Really training staff to focus in on remaining calm, to not get upset. A lot of times, staff end up being the brunt of that person's frustration. And so sometimes it's hard to not take that personally, right? Sometimes it really hurts our feelings, whatever they choose to hone in on or say or do in that moment. But finding positive ways to, reinforce, the situation and be reassuring to the person in that moment, and healthily detach from that particular situation can be helpful for the staff. And then making sure to incorporate a relaxing activity on the spot can be helpful. And those are those things, like I mentioned earlier, related to aromatherapy that can be helpful, or music, or any type of activity where you can engage individuals in something that they find joy in. And again, that's going to look different for every person. And sometimes it's just like we talked about last week, investing that time into figuring out that person and what they need. And then Diesta, I want to acknowledge your comment in the chat. I had a resident that when you attempted to brush her hair from the front would fight you when she viewed the brush, but when you did it from the back and she didn't see the brush, she was calm. So that's, again, I think that's a really great point that you're making about, figuring out what works for that individual. And there could be some sort of trauma in her past life, before she came to the nursing facility, that prompted her to not want to have her hair brushed for one reason or another. You might not never know, or you might not ever know the story behind that, but figuring out what works best can be so impactful for our residents. And then the next challenging behavior we're going to focus in on is repetitive thoughts and behaviors, and in particular, more so those repetitive behaviors that we see. Do any of you all have any residents who are struggling with this piece? I thought I saw some head nods earlier when we were talking about it. Things like pacing, saying the same word over and over again, asking the same question. I believe I've seen a couple of head nods and a couple of hand raises for that piece. So, okay, Morgan's talking about paranoia, about people trying to kill them. So repetition focused on that piece and struggling with that. And Morgan, actually, when we talk about hallucinations as well, I think that part really fits in there. And we'll have, I know that you submitted a case for some things surrounding hallucinations in a resident. So we'll let you share a little bit more about that then. But sometimes those types of behaviors can become repetitive for the individual. And, you know, in my experience working with individuals, I've seen this vary across different settings that I've worked in, and different people, how that anxiety manifests for them. So I worked at a residential facility that was primarily focused for individuals with older adults with intellectual and developmental disabilities. Some of them had outside of their intellectual disability also had issues related to memory loss, cognitive, even further cognitive decline, and different forms of dementia as well. So we saw a lot of different behaviors related to the repetition piece. And so I had a person I worked with who literally every 5 minutes asked you the same question. It was, what's for lunch? The moment you woke her up in the morning and started helping her get dressed and getting breakfast, she didn't care about breakfast. She was so focused on lunch. And even an hour after lunch was over, she was asking you what's for lunch. And it was very difficult to redirect her. She only wanted to talk about this one topic. She's very focused on it. She wanted you to describe the food that you were going to have, who was coming, what you were going to talk about at lunch. So very detailed conversations about lunch, right? And the reason this was problematic is because she really dominated staff time. If she was trying to talk to you about lunch and the lunch plans, she didn't want anybody else talking to you either. And then this was a community where we had one staff member for about 8 or 9 residents. And it really caused a lot of frustration on the behalf of staff, and myself included, because it was like, what are we going to do about this? Because it's such a problem in terms of our flow, in terms of getting things done, and also in terms of just really spending that meaningful time with the other residents who lived there. And we spent some very deliberate and intentional time trying to figure out the reasons for the repetition. After we figured out, okay, well, this isn't going away. We got to figure out some sort of solution here. She's not going to just magically stop asking the question. We've uncovered that, so she had not lived at our facility for very long, maybe like 6 months before I had started working there. And this was a couple months into my tenure there. She had lived with her mother all of her adult life. Her mother had passed away about 5 years before this, and she'd lived with her adult brother for a while as well. And this was something that was so important to her when her mother was alive. And they went out to lunch almost every day. They were ladies who lunched, and they would go to a different restaurant. They'd get all dressed up. And it was just like their special time together, right? Her mother really prioritized making sure that she felt special and felt like she was included in that particular part of her mother's life. And so really what we figured out was this particular resident was struggling with communicating that they missed their mother, and they missed the special time that they had with somebody who was special to them. So what we did was we really tried to turn that behavior into an action. So we worked with her to, and we found this out from the brother, by the way. I should also tell you where we got this information. She was never able to articulate that to us. But we found this out and talking to her brother, and it was something he didn't think to mention because he didn't see it as that big of a deal. So what we ended up doing was we really focused in on having her plan lunch every day. Our residential property also consisted of 2 or 3 other houses that we were able to invite other residents over for. She helped call all of them, invite them over. She would also help in terms of planning the menu. she really struggled with things like the cooking, like the cutting up of vegetables, or really trying to figure out, what the recipe was saying. But staff was able to help her, pull this off every day. And so we really helped decrease that repetition piece by increasing that feeling of her belonging and her contributing to something. So it was really a great opportunity for us to do this. And when we figured this piece out and figured out why she was doing the repetition piece and why this was so important to her, we were really able to focus in on making that a meaningful time for her. It was also great fun for the other residents, so it didn't negatively impact them. They didn't feel like they were not getting attention and that it was all on her. We were able to do it in a way where everybody felt like they had a great time. So I think really investing that time took a while for us to figure out as a team, but overall it really worked. And so what I would encourage you to, if a person's having a repetitive behavior or repetitive question, really figure out, okay, what's the heart of this? What are they actually asking me? Sometimes it's not going to be something benign like what's for lunch that they're repeating. Sometimes the question is going to be a little bit more intensive from as a staff member, from your perspective. It might be repetitive questions about loved ones. So people might draw upon the fact that they might be missing their mother who died 40 years ago, and they're not, if they have any type of cognitive decline, aware that that person's passed away. And so really focusing on that emotion piece, really allowing them to reminisce about the individual, reframe it into a question back to them, to ask them more about that person, to tell them a little bit more about, or to allow them to tell you a little bit more about how special that individual was to them. If it's a person with dementia, you don't want to re-traumatize them by answering, oh, that person's probably dead by now, over and over again, because it's traumatizing to them. We really want to focus on compassionate ways to answer those questions. If you're dealing with something like a repetitive movement, like rubbing tables, rubbing walls, really turn that behavior into an activity to help with the cleaning piece. Or really let them do something that utilizes that energy in a different way. So I worked with an individual that she paced a lot during the in the hallways throughout the day, and she was constantly rubbing her hands up against the walls, and it would drive the staff like crazy, and they were always upset about this because sometimes she didn't always wash her hands in between, things. And so they were worried about her spreading germs. They were worried about, her having food or something on her hands and getting it on the very nice white walls. So we figured out a way to turn that particular piece of her pacing like that into her sitting and folding like laundry, folding paper, doing something with her hands that was tactile, that enabled her to be able to get that energy out. And sometimes it's an anxious thing for individuals. Sometimes they're just bored and they need something to do. And if the behavior is not harmful, like pacing sometimes is not a harmful thing, right? Especially if the person's not at risk for falls, there's no issues related to that piece, just accept it. Sometimes that's a way for them to feel like they're moving, they're doing something. And that's the most compassionate thing you can do, is to really accept that piece and just move on and pick. I often talk in terms of compassionate care about picking your battles and figuring out, okay, is this person really doing anything that's hurting anybody else? Is this making them happy? And it's not bothering anybody? Let's just go with it. So sometimes it's all about those particular pieces of the puzzle.
Hey,
Yes, Chris, you have a question.
I do. I have a friend who's just gotten her first job as a caregiver, and she's really struggling with, well, kind of like what Morgan was talking about, like really, really violent, large scale hallucinations. And her attitude is kind of like, I'm supposed to just sit here and buy into all of these delusions all day? That doesn't feel right. How do we prepare staff for this idea that we're not necessarily going to be able to change the thinking, but that we can respond with the compassion. Like, seriously, what can I say to her to say, Christina, this is part of the job, and this is actually the most important part of the job. And yeah, it feels weird because you wouldn't do this in any other setting.
So I would always counter that with more training in that space, but also I always think about the fact that as a staff member, a CNA, direct support worker, whatever your role is, you're really living in that person's world. And so, you get to glimpse all of these different worlds every day, and everybody's world can be a little bit different. And some people are not going to be oriented to reality, right? And that's okay. But being on that journey with them, being compassionate in the caregiving experience means that you're walking alongside them in that world, right? Sometimes. I think I remember in the 80s, maybe even early 90s, there was something called reality therapy, a little bit different than like there's other forms of reality therapy that I think they use in counseling psychology. But within the world of dementia, reality orientation therapy was all about redirecting that person back to, place and time over and over again. So that might mean that you were telling that person that this loved one they're asking you the question about over and over again was dead. And so, we found that wasn't the best approach with individuals because you were re-traumatizing them over and over again. So,
And I had meant to share this morning and forgot, but I was wondering if any of our participants today have you ever gone through an Alzheimer's disease dementia simulation? There are several out there. We do our assimilation ourselves. And I know just based on responses that I've received from some of the participants, some folks who, professionals, nursing home for, et cetera, who've gone through the simulations, that it really does acclimate them to what Sam was talking about, living in the world of the person who is experiencing the dementia. It really heightens your sensitivity, if I could put it that way, as well as your compassion. And I'm not going to sit here and say that it's easy to do. I took care of my mom for 5 years, and she had brain damage. She had memory loss as a result of anoxia. She had died, and they revived her, and she had been down for a very, very long time, and her short-term memory was significantly impaired. And so that repetitive language and conversation and discussion was one of her behaviors that it can be really, really frustrating. I mean, it can drive you literally up the wall. But and even being a professional in the field, it doesn't matter if you're taking care of someone who have these behaviors. They are challenging, but when you're trained, when you have that knowledge, that information, and especially when you experience it to a certain level yourself, your sensitivity and your compassion is heightened. So I would encourage you, if you've never had something like that at your facility and your staff have not participated, is to look into that and see if you can engage in that type of training with your staff. It heightens the sensitivity in a very, very real way for those who are taking care of persons with dementia.
And to Barbara's point, we do offer those through the Traeger Institute. I actually help lead those simulations. So if you're a facility in Kentucky, I am more than happy to get in my car and drive to you and do this face to face. I wish I could offer it to you all in North Carolina too, but that's a little far. I don't know if person would pay for me to.
We can take a road trip, Sam.
You can stay at my house.
There you go. If Chris houses me, I might be able to pull that one off. We've also done hybrid ones during the pandemic as well, to really help individuals, because we couldn't do some of that stuff face to face. But more than happy to help with that. I saw a couple of people, I think, nodding that they had done this before, and a couple of people in the chat saying yes, that they had participated. So that's really great, because we always love hearing people's experiences and how this particular simulation model helped them in terms of their understanding. I want to go to something really quickly before we move on to hallucinations, actually, in that I want to focus on making sure that we talk about the emotion, not the behavior, particularly related to the repetition. Sometimes individuals, we might not ever understand why they are engaging in that behavior, right? And it could be a limited history that we have on them. It could be that maybe there's no one who even surrounding them knows exactly why, right? Who's part of their care team. So sometimes we just want to focus on that emotion piece, right? So it could be if they're seeming anxious while they're pacing, or if they're seeming upset about something related to their care, or related to just what's happening day to day. Just making sure that we focus on that emotion piece, and sometimes not worry so much about the why piece if we can't figure that out. And then the other thing I want to say is that being patient and understanding can be very difficult. I think Barbara made that point just now. Even as trained professionals, we all get frustrated with the repetition piece. But again, sometimes finding those outlets where you can vent to, other people at the facility and not necessarily taking it out on the individual that you're working with can be very therapeutic. So now we're going to transition into hallucinations, and this is going to be the last behavior we talk about today. And I'm wondering, Morgan, are you on? I would like for you to elaborate, if possible, on some of the things you put in the chat, but also the case that you sent our way that we want to talk about.
Sure. How are you doing today?
Good, good. We're glad that you're able to present.
Sure. So the case that I presented was for a resident in our memory cottage. And this behavior, the hallucinations and the paranoia, were present before moving into our community. The family did disclose to us that their loved one had a diagnosis of PTSD. This resident has a very specific trauma that was important for us to know, that when in the war, he was one of the sole survivors of his platoon following an invasion one night. Basically, the way that his son described it is that they were told to always keep their boots on, even when they sleep. And he was the only one that did, and the rest of them did not. And so he got out. What that has turned into as far as now, when he was living at home, he had a lot of paranoia that his neighbor was trying to break into his home and kill him. So he would barricade the doors at night. We see that same behavior here. He does from time to time have these hallucinations, paranoia that someone is trying to get into his room and kill him. So he will put a nightstand in front of the door, or he'll take a chair or something and try and block the entry door. Now, our staff have learned how to work with him on that. But another key component to that is that if staff go in to check on him or take him something, help him with something, and he is asleep, we have to be extremely cautious with how we awake, if we're going to wake him up, how we do it, because of that same traumatic memory for him. We have to really stand far back and call his name and really make sure he knows we're there and he's awake, or he can strike out at whomever's there trying to get his attention. We've had some situations where the same resident, if there was another resident having some sort of agitation, or they were, cursing at staff or what have you, it would make him very upset, and he would either speak up and kind of use his cane to direct how he felt about it, or he would kind of withdraw to his room and then barricade. So very clearly can see how that traumatic and emotional memory is still there and still affecting him now.
So thank you so much for sharing that. I'm gonna ask you a couple questions, okay? And you may or may not know the answer to them, but I think this might help all of us kind of generate some recommendations. So at night, is this happening predominantly at night that he's having some of these terrors, or does it also happen during the day?
Mostly in the evenings and at night.
Okay. All right. So the thing that I'm going to suggest first is that, and Barbara, feel free to jump in on this, and Chris, Justin, others as well. I'm going to suggest that you think about maybe if you're not already doing this, this might be something you've tried, is think about using light in his room. Because sometimes what happens is, especially as lighting changes in the room from dusk to night even, and then in the overnight hours, he might, because of his PTSD and because he's hallucinating, sometimes it's the changes in light that cause us to see things that aren't necessarily there. The other thing is, if there's a mirror in his room, consider either removing the mirror, because that could be causing him to think there are other people in the room, or startle him if he wakes up and he sees his own reflection, but he can't tell that it's him. Or putting, if they really want to keep the mirror in the room, covering it could also be something that's helpful, especially at nighttime. So he can, only uses the mirror during the day. Making sure that noises, you can try a couple of things. And again, this is sometimes trial and error. You want to make sure that he's not hearing like the TV from other people's room or noise from other people's room, anything that could be loud, because that's going to play into that. I survived this very intense traumatic thing where I'm sure there was a loud noise that happened that precipitated it. So you're going to try and avoid that. Some people that I've worked with who have dealt with PTSD find it soothing to have like a noisemaker in the room playing soothing sounds to drown out everything else or the potential for any other noise. Some people that doesn't work for it, makes them more agitated. So you're going to have to kind of play around with that and see what works best for him.
Thank you.
Yeah, what other questions do you all have for Morgan that might help us to flesh this out a little bit more too? What else do you need to know to come up with some suggestions? Sam gave us an excellent start. I'm watching you think.
And Morgan, do you have any other questions?
No, I don't think so.
I want to ask the medication question, Morgan, but I know, yeah, I won't be able to speak intelligently to it. And Dr. Citrone's not here. Justin just put a comment from her in the chat. Is it possible that maybe we don't have to go in his room ever at night? Can we just make a rule?
Well, I mean, we do have to check on him for safety, but staff are very careful about just opening the door enough to be able to check and make sure he's okay, and not going in and taking the trash out or going in and bringing laundry in and out and those kinds of things.
Right, that's terrific. That was
And
her
he
first
is prescribed a medication specifically for his PTSD. And we have worked with his physician on increasing and decreasing that as we see, the intensity increase. But it's also very tricky because he has the dementia component as well.
Yeah, I gotcha.
Yeah. I would also suggest too, Morgan, when I know, having worked in facilities before, those overnight hours, you typically have kind of a schedule. You go check on this person at this time, or you do this one side of the hall at a certain time, right? So I wonder if you could also let him know what times those are. As well. So have like a schedule, like when staff are coming. I don't know if that's going to help in any way, but it could help, I guess, in general, of one, communicating that like it's 2 a.m. we're going to come check on you, right? So if he has a clock in the room, he can glance at it and know that it's about time for somebody to come check. So maybe that would be less disruptive for him. if he's able to be aware enough to look at the clock and know and make that connection, he might not be able to, but something to
Yeah.
think about.
Yeah, another hard piece to it that I don't think I included in my write-up for the case study is that he also wears hearing aids, and sometimes he's compliant with that, sometimes he's not. Sometimes, and with our residents that wear hearing aids, we do, when they go to bed at night, we collect the hearing aids and keep them with their medications and stuff so that they don't get lost. And so I think that the hearing deficit also plays into it,
100%.
but also hard to determine, is that really his hearing worsening or is it his cognition getting worse? So
Mhm.
hard to tell.
And, I would say too, there's, a connection between those things. When we talk about why hallucinations happen, we know that sometimes it's not just tied to the cognition piece. Sometimes it's eyesight or hearing issues that are causing it. Sometimes it's, physical things as well. Doesn't sound like this is the case for him, but even like infection, dehydration, intense pain, all of those are things that can contribute to hallucinations in people. For him, it's probably that combination of obviously the PTSD and the dementia diagnosis. But we always, if somebody's just presenting with these, we kind of want to rule out some of these other areas and what we can do to help, with that particular piece. But in terms of a question I would have is his hallucinations seemingly worse, or those behaviors that he's having seemingly worse when he doesn't wear his hearing aids? Is that what you're saying?
Not necessarily. I just think it's, in knowing the case, I think it's important to understand that there is also a hearing deficit in there that obviously can play into some delusion or some hallucinations as well.
Yeah.
So, and then it also doesn't help that we're in the middle of renovations in our building as well.
Oh, no.
Oh, no.
It's kind of a perfect storm situation, but
Yeah.
And is he a new resident, you said, Morgan? How long has he
Yeah.
been? How long?
he's been with us a little over a year, maybe close to a year and a half.
Okay, I was hoping you were gonna say like a month and I could say, oh, maybe it'll get better.
Well, and it does go through phases where it's better,
Mhm.
and phases when it's worse. So there's not a real rhyme or reason that I can put my finger on. We just kind of take it day by day with him of how he's doing each day, and we adjust with,
Is
you
it,
know,
is it better when his son has visited or is it worse?
I don't really see a trend of any difference.
Okay, yeah, these are tricky.
And what concerns me is that now we're seeing some declines with his independence as well. He was very independent physically when he got here. And so now we're starting to see some declines with that, and he's not very cooperative to allow people to assist him, particularly with like showering and cleaning up after toileting, and that's where we're seeing some concerns now.
Mhm.
And so, I look at this and say, okay, what's going to come now that we're having to increase assistance with him for, for safety and health wise. So it's it can be tricky for sure.
I only had one other question, and I know I'm hogging the airtime and we're almost out of time, and I apologize. Is there anything that he uses for self-soothing? Like, this is gonna sound silly, but a teddy bear, something in the bed at night that would be soothing?
No.
Nothing during the day. He doesn't have a,
He likes to watch TV in his recliner, and that's
got
his.
it.
Sometimes he'll come out. He'll come out for meals. Sometimes, occasionally, he will, sit in the living room or sit out on the porch. I don't know that this has any effect, but 6 months ago, he had a very good, friendly relationship with a female resident here in the cottage. They would sit together and eat meals together, and it was just very much a companionship. And now she is declining at the same time. He's starting to show some declines. As I said, I may be overreaching with that example as having an effect, but I don't know.
Yeah.
It could be another change, another loss. and him feeling like not being in control, which sometimes makes hallucinations worse or more profound because it plays into that sense of I don't have control over what I'm seeing right now, or hearing for that matter. So Morgan, I have a couple more things that I'm going to type up and send to you with some resources. So
Thank you.
expect an email from me. I'll follow up. I'll put in these things that we discussed today as well. And if you have other questions, I'm more than happy to talk through this a little bit more as well. We can schedule time if that's helpful, or you can just see the stuff I'll send you via email.
Okay.
And
Thank
then
you.
yeah, and thank you so much for presenting. I think this was a great case, and I'm sure very helpful for everybody else to hear about as well. We do have next week a focus on social isolation. And so if you have any challenges related to that, or I guess just anything at all, you could put that in the case study form and we'll review those next week. So bring us your cases. We want to help you with that particular piece. It's week 19. So this is our session survey for this week. Justin has put both the case study link and the session survey link in the chat for you. And then I'm going to turn it over to Pam to talk about advanced care planning really quickly.
Thank you so much. Yes, I wanted everybody to know that the session survey, all of the CDP information has actually been extracted from that. So that's good. So the survey, you won't see any of that kind of language in there anymore. But moving forward, we wanted to let you know that at some point in the next week or two, we will be sending out an email to individuals that you identified in your orientation survey that would have information about advanced care planning information. As part of our HRSA grant, we are required to go on and provide some baseline data about our nursing home facilities as it relates to the rate at which we're using advanced care planning documents with our residents. And so there'll be a few questions, and then there'll be a place where you can add, the total number of residents that you have and how many in that particular. We're going to do a very small time frame. We're going to do it 1 month. And then the hope is that we'll get an understanding of our baseline. And then after we receive training on advanced care planning, that we'll again do that to see if there's some movement and uptake of the information that's being imparted during that particular training. So this particular announcement I'm doing right now is our very first announcement where you're going to hear about it. I may be sending emails to some of you asking you. I noticed that you maybe didn't have a person to identify on the orientation survey, or you maybe you did and that person is gone. If we get a bounce back email, but we wanted to let you know that this is coming. And if you would either answer the email from me or Ellen Roberts regarding, can you tell us who that person would be that would likely have that information regarding the data, or if just be receptive to those types of things if we end up sending it to you because we don't have anybody. But we'll be talking about this again next week and in coming weeks. So thank you very much.
And thank you all for a great session. Morgan, thank you for presenting. Thanks for all of you who shared in the chat or unmuted yourself today. This was great. If you have any questions, I will put my email in the chat for everybody so you can find me quickly. But more than happy to talk through any